You know, in medicine, sometimes the most dangerous thing we can do is misinterpret a sign. Today, we're going to tackle akathisia, a really severe, medication-induced turmoil that can look exactly like the very illness we're trying to treat. It's one of the most distressing experiences a patient can have, and our job as clinicians is to see it, name it, and most importantly, break the cycle.
Now, you might read that and think, okay, agitation. But no, this is so much more. This is a patient's own words trying to describe the internal chaos of akathisia. It's a profound, just unbearable sense of inner and outer restlessness that goes way beyond simple anxiety.
To really understand this, to really get a feel for this profound distress, we have to see it through a clinician's eyes. So let's step into the clinic with a case where spotting these signs made all the difference.
Okay, so here's our patient. He's 45, has schizophrenia, and he's on a new med. But now he seems more agitated, more withdrawn. The team's first thought? His psychosis is getting worse, and their instinct is to increase his medication. But is that the right move? As we're about to see, that could be a huge mistake.
Now, this is where you really need to put on your detective hat. The timing here is everything. This isn't just some random change. The intense restlessness kicked in about 5 to 6 days after starting a high-potency antipsychotic, haloperidol. That link, that specific timing, is a classic, high-yield clue that should make you think, wait a minute, maybe this isn't his psychosis. It's pointing us directly toward a medication side effect, acute akathisia.
So what does the care team actually see when they examine him? They see these really distinct motor signs. This isn't just fidgeting, okay? It's a compelling, irresistible urge to move. And that marching in place, that is almost pathognomonic. It's such a specific sign. These are the objective, observable signs of that subjective inner turmoil we talked about earlier.
Okay, so let's start our clinical reasoning. We have the timeline, right? We have the patient's subjective distress, and we have these objective motor signs. So how do we put all these clues together to nail the diagnosis?
This right here, this is the critical fork in the road, the key differential diagnosis. Are we looking at a worsening of his primary illness, or are we looking at an iatrogenic side effect, something we caused with the treatment? Getting this wrong can lead to a really dangerous situation for the patient. Getting it right is absolutely everything.
So what's actually going on in the brain here? Let's break it down. Antipsychotics like haloperidol work by blocking dopamine D2 receptors. And while that's helpful in some brain pathways, when it blocks D2 receptors in the nigrostriatal pathway, which is like the brain's superhighway for coordinating movement, it messes everything up. It creates this signaling imbalance, and that disruption is what shows up as the inner restlessness and the compulsive need to move that we call akathisia.
In the name itself, it literally tells you everything you need to know. It comes from the Greek akathisia, which means an inability to sit still. And remember, it's always got two parts. There's the subjective, internal feeling of torment and an objective, observable movement problem. You need both.
All right, we have a really strong clinical suspicion of akathisia. So what's next? Our job now is to confirm it and, more importantly, get this patient some relief, fast. So let's look at our toolkit. This table shows our main treatment options. The big takeaway here is that we have several effective agents. Propranolol, a beta blocker that's lipophilic, meaning it can cross the blood-brain barrier, is considered the standard of care. But we also have other good options, like the anticholinergic benzotropine or even the antidepressant mirtazapine. The choice really depends on the patient's whole clinical picture.
And here's the best part, the resolution. The diagnosis was confirmed because of the rapid, almost dramatic response to the treatment. This is a powerful clinical tool we call diagnosis by treatment response. Giving him propranolol didn't just provide immediate physical relief. It also calmed that cognitive chaos, allowing him to finally tell us about the profound distress he'd been in.
Okay, so that was one case. But let's zoom out now and really solidify the clinical essentials. This knowledge is so critical because akathisia isn't just about one patient or one specific drug. This is so important to remember. This is not just a haloperidol problem. A lot of common dopamine-blocking medications can trigger it, including the newer antipsychotics, anti-nausea meds like metoclopramide, and even some SSRIs. Your big takeaway here should be to always keep akathisia on your differential diagnosis when a patient on one of these drugs develops new agitation.
Okay, this is a classic exam question, but it's also a real-world dilemma. Akathisia versus restless leg syndrome. So how do you tell them apart? Well, the key is the quality and the location of the feeling. RLS is more of a creepy crawly sensation, mainly in the legs, and it's usually worse at night. Akathisia, on the other hand, is a global sense of inner restlessness affecting the entire body, and it's there all day. And don't forget that marching in place sign. That's highly specific for akathisia.
And this is the trap we absolutely have to avoid. It's what we call the vicious cycle of misdiagnosis, and it's so easy to fall into. When akathisia is mistaken for worsening psychosis, what's our first instinct? To increase the dose of the offending drug, and that just makes the akathisia and the patient's distress exponentially worse. Recognizing akathisia is the only way to break this harmful cycle.
All right, pop quiz time. Let's see if you can spot it in the wild. Case 1. A patient on an SSRI for depression suddenly has new suicidal thoughts and can't stop fidgeting. That's akathisia. Case 2. A post-op patient gets metoclopramide for nausea, then becomes super agitated and tries to climb out of bed. Akathisia again. The pattern is always the same, a new restlessness that's linked in time to a new medication.
Okay, let's wrap this up. What are the absolute high-yield points you need for your exams and, even more importantly, for your clinical practice? Let's distill it all down.
If you remember nothing else from this, burn these points into your brain. Akathisia is subjective restlessness plus an objective need to move. The classic cause is high-potency antipsychotics. Look for that marching sign. Know how to tell it apart from RLS, and whatever you do, beware that vicious cycle. First-line treatment, propranolol. Got it? Good.
Okay, let's test that knowledge. First question, what's the classic timeline for acute akathisia to show up? Typically, you'll see symptoms pop up about 5 to 6 days after starting or increasing the dose of the problem medication.
Question 2. A patient on metoclopramide is constantly shifting their weight and tells you they feel like they are jumping out of their skin. What's the diagnosis? That is a textbook presentation of akathisia, caused by that dopamine-blocking anti-nausea drug.
And last question, what's the core mechanism behind antipsychotic-induced akathisia? It's all about the blockade of dopamine D2 receptors in the nigrostriatal pathway, which just throws the brain's fine-tuned motor control system out of whack.
So, at the end of the day, the most crucial takeaway is this. Recognizing akathisia is not just good medicine. It's a deeply compassionate intervention. It prevents us from causing harm, and by relieving such profound distress, it can be genuinely life-saving.
So I'll leave you with this final question. The next time a patient on one of these medications seems to get worse, will you remember to ask about restlessness? That's our explainer on akathisia. Thanks for watching, and stay curious.